Very warm welcome to all our delegates and friends. There are two things we miss this instruction course. Firstly, it has been an amazingly popular course for the past 5 or 6 years, and that's because the chief instructor used to be Dr. Lingam Gopal. We miss him right now here, but he is joining us as a panelist. The second thing, of course, we miss is the fact that we are not in physical meeting, and we hope that by next year that will change. But making the best of the situation we have, we thought keeping part of the previous year's formats that have been so popular, the questions that have been posed to us over these months and years, we've tried to address in this instruction course, which we call Retinopathy of Prematurity, All That You Need to Know. So we have 5 speakers today, and you'll see them as we move along the list. What I'm going to do now is, before each speaker makes the presentation, I'm going to ask the 4 or 5 questions. They will then talk, and they'll probably answer those questions in their presentation. And if not, we'll cover it in a 4-minute panel discussion just after that talk before we move into the second talk. Right. So I invite Dr. Karogi Lahiri to make the first presentation. She's going to be talking about examination techniques and screening in the Indian context. The questions for you, Dr. Karogi, are: what are the pre-screening protocols, especially a day before? What is the ideal dilator drop? According to the 2018 guidelines, which babies should be screened, how often, and until when? And are there any advantages of image-based screening versus conventional screening? So, Dr. Karogi, over to you.
Thank you, Anand. I will go directly to my talk, which is on ROP examination and screening guidelines. These are babies of different weights and different gestational ages. You see that they are from little better to little worse to absolutely moribund children. And why should we worry about this condition? The incidence of this condition is rising so rapidly in developing countries, but with improvements in neonatal care and increasing survival of low birth weight infants, we get these children surviving, but they have to go through a lot of torments while they do this. Out of 26 million annual live births in India, approximately 2 million are at a risk of developing ROP. And in India, the incidence of ROP is between 38 to 51.9% in low birth weight infants. WHO has recognized that prematurity is one of the major causes of neonatal mortality. Globally, 50,000 children are blind from ROP annually. That was in 2008, 32,000 in 2010, and out of this, 10% is in India. So WHO says that born in that report of Born Too Soon, they have said that India has the largest number of premature babies, that is almost amounting to 35 lakh premature babies annually in the world out of 15 million worldwide. So the thing is that a premature baby requires examination not only by the neonatologist and the pediatrician. We ophthalmologists play a large role, and later the ENT person, the optometrist, the vision therapist, and all the other therapists also play a very vital role in the good development of these children, so that the quality of life in these children can improve. Now, what are the screening guidelines? The screening guidelines, according to the US criteria, was birth weight less than 1250 grams and gestational age of 36 weeks. But we have universal eye screening guidelines from the RBSK, and the new National Neonatology Forum has currently set out the guidelines in 2010. Here they mention that all infants weighing less than 750 grams at birth or less than 34 weeks of gestation, or even babies who are heavier than that, that is 750 to 2000 grammars, or older babies between 34 to 36 weeks should be screened depending on incident attending risk factors like mechanical ventilation, child has been on prolonged oxygen therapy, there is hemodynamic instability in the patient, there is adverse respiratory issues, and if the cardiac disease profile is prominent. Now, large babies are known to get vision affecting ROP, especially in our part of the world. This is multifactorial. This is because of poor antenatal care, including anemia, which plays a major role, poor weight gain, possible absence of antenatal steroids to high risk mothers, suboptimal post care with respect to oxygen monitoring, giving of antibiotics heavily, sepsis prevention is not good, nutrition of the baby, blood transfusion strategies, and possibly genetic factors. Now, the ICROP classification has said that they divide the disease as per location, extent, and plus, but APROP really doesn't fit into this categorization. The ROP, the location depends, is three zones. The first zone is a concentric circle which is centered around the optic nerve, and it is the distance, twice this distance from the macula to the center of the disc. You circumscribe a circle. Then from the edge of that circle to the nasal aura is another circle which gives you zone 2, and zone 3 is whatever temporal crescent is left behind. And these are the stages that you can go through. I'll just go through it one by one. This is all together up to stage 5, where you see the cicatricial phase at the end. Now, to go over this, stage 1 is where there is formation of a demarcation line over here, where you see with the arrow. Then these demarcation lines, the blood vessels start arborizing on that, that is stage 2. Then these arborized vessels start moving into the vitreous, which is the extra fibrovascular proliferation, and then that is stage 3, and then there is advanced stage 3, and then if there is a nasal aura traction developing, that is stage 4A. Stage 4B is where there is temporal traction, and when the entire thing lifts up and it goes into age of cicatrization, that is stage 5, where the entire retina is lifted, and at the end stage of this you get the very classic leukocoria, that is which you see in the lower right hand corner. Then there is a variant which is called as plus disease, which is dilatation and tortuosity of blood vessels and arterial congestion. And these are patients where you have severe 4 quadrant plus. So these are the three types that we have: aggressive posterior ROP, which is where the vascularization ends in zone 1 or very posterior zone 2 and is accompanied by plus disease, which progresses very rapidly. And this affects very low birth weight babies. Threshold disease is that disease where there is 5 contiguous continuous clock hours or 8 contiguous clock hours of effect, and this is the threshold which is like a moderately less severe form of ROP but still has to be tackled. And pre-threshold is, there are two types in this, that is type 1 and type 2. In type 1 we have zone 1, any stage with plus disease, zone 1 stage 3 without plus disease, zone 2 stage 2 or 3 with plus disease. And the type 2, which is less fulminant and which is safer, is zone 1 stage 1 or 2 ROP without plus disease, or zone 2 stage 3 ROP without plus disease. So this is the same thing reiterated again. And as I said, that aggressive posterior ROP is a very, very fulminant form of ROP. And if you see the very kind of active tunica vasculosa lentis, which you see in the photograph, and this manifests very early as sometimes 3 weeks. We've seen it coming at 2 weeks also sometimes, and it goes into alarming stages of cicatrization by 6 to 8 weeks. This, which is generally the time when the threshold ROP starts requiring treatment, and ICROP does not categorize this form of ROP. So these are other pictures to show you the APROP, or it was called rush disease or fulminate disease earlier. And there is something called as pre-plus and plus. Plus I already mentioned, venous dilatation, arterial tortuosity, where there is iris vessel engorgement and poor pupillary dilatation with vitreous haze. And pre-plus is just an arterial tortuosity and venous dilatation, but which is less than normal. So this is just to show you a graphic where the blood vessels are going, and then the extraretinal fibrovascular tissue growing in, which tends to increase into the eye the minute you. Uh, and this is just another animation which we have created, which just shows you what the child has to be, what has to be accomplished in the child.
And the retina is visualized with the help of the indirect ophthalmoscope. Stages. Stage 1 shows a clear demarcation line between zone 1 and zone 2. Stage 2, this line becomes a ridge. Stage 3, the ridge widens between zone 1 and zone 2. Vessels grow onto the ridge and widen and become varicose, leakage on ridge. Stage 4, there is partial detached retina where vessels pull retina into the vitreous. Stage 5, the retina detaches completely.
So now let's come to the why, when, where, how, and what of ROP. This is a severely sick small child, and the initial screening was earlier thought of as 4 weeks, but as I just mentioned, now we generally see them at about 3 weeks. Children with the criteria that I mentioned above, and where the first examination is generally in the NICU. Okay, and the thing is, the accessories that you require are those of the indirect ophthalmoscope, speculum depressor in children, like in patients, in people who are examining for the first time. They would be comfortable if they do it with a speculum and depressor, but the indirect ophthalmoscope is absolutely a necessity. These are different kind of depressors which are available in the market. The most commonly used is the Alphonsus one, and there are a lot of depressors which come in a pre-sterile pack, so you don't need to sterilize these instruments separately. Otherwise, you sterilize these instruments and then use them for your examination. The pupillary dilatation is accomplished by using cyclopentolate 0.2% and phenylephrine 1% combination, or a combination of phenylephrine 2.5% plus tropicamide 1%. Now, tropicamide or cyclopentolate is put every 15 minutes for 1 hour, and the phenylephrine, which generally comes in the 10%, you dilute it 4 times and put it at the end. There are some formulations which come with half the concentration, where you need a single dilution of these. We put it at the end. Now, the examination has to be short, thorough. 1 drop propofol is if with depressor and speculum. If you want to put a sugar pellet, you can put it. Glance at the posterior pole, tilt the head to view the other quadrants. A 20 or the 28 diopter of lens is required. The guidelines which there are newer recent terminologies like immature retina, where the retina is the blood vessels, the severe one is where it is just at the border of the arcade. The medium, the moderate one, where it comes to the posterior part of zone 2, and the mild one, which is detected up to the posterior border of zone 3. The other one is half zone ROP, which is again a very, 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 very severe form of the disease, as you see in the picture over here. There is something called as a tungsten filament sign, which is following intravitreal bevacizumab, where a shunt occurs, which looks like a bulb. And the take home message is that main challenge is producing the baby within 21 to 30 days. The child is not born with ROP, and it can be treated with timely intervention. Thank you.
Thank you, Dr. Karuvi. I think that was perfectly on time. The talk is over, and I think you've addressed some of those questions. We now
Yes,
have this
I
4 minutes.
have to talk to you about
So I think to summarize, I think you spoke about the dilatation, the
I
pre-screening.
just have to tell you about the guidelines which you following the when you go for the examination,
Meanwhile,
right?
I also want to point that Dr. Subhadra and I have put the links and details in the chat box for the attendees. You all can look at that. Yes, please, Dr. Karuvi, go ahead.
Yes, so the evening before, it's always to be prepared for ROP examination. So the evening before you go, you check with the sister and you give them an approximate time when you would be there. Ask them to take the consents, check that the child is there, not transferred out, or anything wrong has happened, or sometimes the child is shifted, from one NICU to the other. And then you have a consultation with the pediatrician also as to the course of the child. And then the next day when you go to see that the consent forms are signed, you have to generally this wash your hands, glove yourself, wear a gown, and then you take the necessary sterilized instruments with you, whatever you require. Of course, the indirect ophthalmoscope is not sterilized, but you go and you examine these children in the NICU. And after you come out, a very detailed report of how the child was dilated, from what time the child was dilated, with which drops the child was dilated, and the findings in details have to be written on either the patient's file, or if there is a card, and you have to give them a little card of the next follow-up of the child. So these are few things which you have to follow to avoid any kind of medical legal hassles later.
Thank you. Can you also stop sharing your slides, please, so that we can...
Oh, it's still sharing? I'm sorry.
No, it's fine. So I think Dr. Karobi brought out a very important point here about documentation. And legally speaking, even the dilator drops, the fact that the baby is being dilated has to be mentioned. Earlier, I think most of us were not doing that, but it is a drug, and some of the court cases have actually mentioned that is a very important prerequisite. Earmarking which babies need to be screened the previous day, going on that day, trying to have a fixed day for each NICU. All of these sort of make it into a program rather than an ad hoc screening where you say any day you can come and I'll screen you, especially if you're attached to an NICU. Very good. So to summarize the 2018 guidelines, since that was a question, less than 2 kilos, less than 34 weeks, one screening before the baby turns 30 days of life, 30 din roshni ke, as Dr. Subhadra always famously mentions, and definitely not more than 30 days. The babies who are 1200 or lesser or 30 weeks or lesser, like the old NNF guidelines, can be screened even earlier, that is between 2 weeks and 3 weeks. There's also a move now to screen the babies at least once before discharge. We know that a baby may not have ROP maybe at 7 or 10 days of life, but we are going to include them in the screening program, and that is systemically safe, because once you capture the demographic details of the mother and the baby, you are able to tell them to come back rightfully at the correct time, and this is much better than asking them to come first time after discharge, when we've seen, especially in the rural areas, that they are missed to follow up. So these are some of the things. I think the last thing that is not touched upon is imaging versus conventional. Of course, imaging may be preferred, but it's not everyone has the camera, and where it is possible, it works great. You don't have to have an expensive camera. You still can do with photo documentation using cheaper bedside cameras, and going forward, that may become an important legal document. Perfect. I think we've come to the end of that discussion and the presentation. Thank you once again, Dr. Karobi. We'll move on to our second talk. Dr. Subhadra Jalali. None of our speakers need any introduction, so I'm not doing that. Dr. Subhadra ma'am is going to talk about risk factors and its mitigation, but we've also sort of combined questions for her. Ma'am, your questions, classical versus AP-ROP, how do they differ, especially in terms of these systemic risk factors, and what red flags? And if you see a full-term baby with an avascular periphery, as we sometimes are called to examine, what would be your advice? Third, when would you suspect Roper, which is ROP with FEVR? And in other words, when would you point this baby towards genetic testing? And finally, any perinatal or systemic treatments that you would ask the neonatologist specifically to look at, or would you ask in the history when you're examining these babies? Ma'am, you have 12 minutes, and then we'll take over the questions which are left.
Okay. Am I audible?
Yes, ma'am.
Yes, ma'am.
Okay. So let's go to the risk factors and mitigation of these risk factors, which is sort of a primary prevention. I think, our sustainable development goals say that, we should prevent some morbidities, we should have a healthy life, we should have, health goals are there. But if you look at ROP, this is a condition that is actually promoting blindness. Everything that is happening in these babies is leading towards blindness. So we know that, it's sort of an iatrogenic disease, because we know it's not an ancient disease. It's not a naturally occurring disease. Preterm babies who are born at home for centuries, they didn't report any ROP. It was only when the first incubators were set up in 1941 in Boston Children's Hospital that in 1942 the first ROP were, detected. Of course, there have been other incubators which were there before Boston Children's Hospital set up, and there have been reports of ROP in those babies too, but this is the first documented case. So we have to know that, the smaller survivors will have highest risk, and the main risk factor is the suboptimal care, where the baby survives but gets very severe ROP. So ROP has a natural history, that it will start with the normal retina, then it will have dichotomously branching vessels, which is an immature retina, which is perfectly okay for their age. And then slowly, these vessels will branch further and grow further. So that is natural. If ROP occurs and we don't treat it, then we know it goes into 4B or 5. But if we treat, then, it should resolve. So this should be the natural course. I get so many times phone calls that I have lasered the baby, it's not responding. Why it's not responding? Because we have not taken into account the systemic risk factors. Everybody should know that ROP is not a retinal disease. It's a systemic disease which affects the retina. And the first clue you get that something is wrong is when your treatment doesn't work or the disease doesn't follow what is expected to follow. But we should not wait for that. We should be preventive aspects should be taken care of right from the beginning. So it's the ideal condition to screen, and data has shown both from the West and from our country that if you give high quality care to the babies, then the amount of ROP becomes severely less, and also the severity of ROP reduces. The type of ROP you're dealing with, very fulminant ROPs, you don't see those. So if you look at NICUs of RP Center or PGI or even in our city, Fernandez and all, we hardly see any ROP. And if we see, it's a very mild type of ROP and very rarely we have to treat. So these are some of the things that we want to take care of. Antenatal steroids, sepsis control, oxygen control, weight gain of the baby, transfusion policy, of course, warmth and care, which helps the baby to grow both cognitively and so the kangaroo mother care is important. I think in a lot of this, nurses play a major role. So education of nurses, taking classes for nurses, explaining to them that whatever they do or don't do is going to have an effect. There's something called a bundle care. Bundle care means that don't keep on disturbing the baby for different things. Once the baby is there, somebody will go and feed, then somebody will change the diaper, then somebody will take a blood sample, then somebody will adjust the oxygen, then somebody will come and screen. No, there should be a single time where everything is done for the baby and let the baby sleep and rest. Don't keep on poking the baby for one thing or the other. That helps the baby to gain weight. So there's a warning here which I have put that you can get severe ROP in large for gestation age babies. So if baby is born to a diabetic mother or had hydrocephalus or some renal problem or intestinal distension, baby may be a large baby. It may be 3 kg baby, but if it's a 30-weeker, 32-weeker, what we call as large for gestation babies, they can get severe ROP and they get missed because of the false high weight. Does the mother's health affect the baby? So there are very few studies which have shown that any inflammation in mothers may be causing more ROP. Our study, which we did some time back, showed that children born to anemic mothers had a poorer vascularized retina at birth than those who were born to well-fed mothers. So I think the maternal care is very important. So if you know there's a high-risk mother, like an IVF mother or a mother with placenta previa, make sure that she is not anemic, she is gaining good weight. Then the baby will also have better weight at birth. So can we prevent premature births? Of course, we are having all these situations where actually the premature births have increased rather than decreased in spite of so much of science, scientific advance. Actually, the number of preterms has increased a lot because of assisted fertilization, early teenage and elderly primary pregnancies, poor maternal education level, poor nutrition, lack of access to care. So they go and deliver very early. And of course, there's something like close fetal monitoring. So people are very concerned, the obstetricians are concerned that they should not have a fetal death. So, if the baby is born, stillborn or dies in utero, then their hospital will be burned down. So they are doing very close fetal monitoring, and at the earliest sign of distress, they will, deliver that baby. So they show a live baby and then their problem is solved. Then it is a neonatologist headache. So yes, there is going to be close fetal monitoring. Fetal deaths are no longer accepted in societies unless, unlike my grandmother, she had 8 children, 3 died in birth. It was accepted. Today, it's not going to be accepted. So there is going to be a lot of prematurity and we are not going to stop it. So antenatal steroids are very important. They are now a policy of the government of India. Already the National Health Mission has sent this dictum to all the states and all the obstetricians that all the high-risk pregnancies should take antenatal steroids, should be given parenteral antenatal steroids. Also, there is some evidence that, even the late preterms, those who are born after 34, 35 weeks can be given. And if the mother didn't come for antenatal care or she suddenly had a precipitate labor, then also just before delivery, one dose should be given. And this protects the lungs, protects the intraventricular hemorrhage, and also improves the ROP outcome. So data is there. Now, oxygen has been not talked about. Oxygen does not cause ROP, but oxygen worsens the ROP. So it is very important to know what are the oxygen management things. One of the things which again Government of India policy is there, what is called as in utero transfer. So if you know that patient is at high risk and going to deliver, it's good to transfer the baby to a neonatal center where neonatal care is available if it is possible. The first golden hour is very important. How the oxygen is monitored in the first hour. I'm not going to go into details, but just to say the practice is as soon as the baby is born, it's a high-risk baby, they will just poke oxygen into its body, whether it needs or it doesn't need. So a normal baby can have, 70% saturation, 80% saturation for 7-10 minutes. That is natural for it. You don't have to force it into oxygen. So guidelines are there, how many minutes of how much saturation is allowed, and only after certain guideline you give oxygen. Otherwise, you don't give oxygen, and also that is to be given as a blended oxygen. Then you can start with non-invasive therapies, CPAP. So don't push oxygen that much. So again, I'm not going to go to all the details. There's a lot of data, a lot of studies, a lot of controversy. What should be the oxygen saturation? So in general, the meta-analysis study in NEOPROM showed that 91 to 95% is good, both for survival and not an increase in the disability like cerebral palsy and things like that. So in my center, whenever I go to an NICU, I talk to the neonatologist and the nurse and make sure that the pulse oximeter reading is not crossing 95. And more importantly, it should not fluctuate. So watch the baby. If it is fluctuating, it's going to 60, then 80, then 95. So that's not good. That's not good. So it should be at a very steady pace. So obviously you need a lot of nurses to do that. The challenges in our country is that we don't have enough pulse oximeters. There will be 2 pulse oximeters and 20 babies. So it will be put on the VIP baby or the sickest baby. Blenders with air are not available. They're very expensive. So fortunately, a couple of people in the country are now trying to make the blenders in India. And hand washing and asepsis techniques and antibiotic abuse. So what people think is that because baby is high risk, let us push imipenem, let us push high-end antibiotics, then it will not get sepsis. So this is a very bad policy. It leads to a lot of morbidity in the baby. So, proper antibiotic policy should be there. And the NNF is, pushing for antibiotic heroes nowadays. So weight gain is other thing. The moment you see a baby who's very tiny, in spite of 2, 3, 4 weeks, you know that this is at a high risk. Sometimes they'll keep on coming from certain centers where they put the baby on IV saline for days together and don't start the feeding because they are concerned of NEC. So it's very important that breast milk should be given right immediately after birth, every 2 hours, and supplement feeds can be given. And asepsis is very critical while giving these feeds. If the baby gains weight, then its ROP will also be very less. The lungs have a direct impact on the eyes. So it has been seen that, if the child gets frequent pneumonia or chronic lung disease or lungs are immature and child is getting into apneic spells, there's a lot of VEGF which is secreted by the lungs because the lungs need VEGF to get better. And so this goes into the eye and worsens the ROP. So there are a lot of steps to be taken throughout the care of the baby. And even when you are screening or you are doing the laser, make sure that, the lungs have been taken care of. You have a dialogue with the pediatrician and the parents that, child's nose is blocked. You need to keep it clean. You need to make sure child is breathing well. Then anemia. So the blood transfusion, again, there has to be a blood transfusion policy in the NICU. So again, I'm not going to go into that. The NNF has given guidelines when to give. For our usage, we want that baby should not be anemic. Almost 80% of babies are anemic when they come to us for surgeries or they have APROP. So always get the hemogram checked and the platelets checked and the RBC checked. So all of them have concern if, your treatment will not work if the baby is anemic because it is getting a hypoxic retina. So these factors should be corrected as per the guidelines as you are screening and treating these babies. So we give the treatment laser today, immediately same time we send for hemogram and say, get it checked and get it corrected. So to recapitulate, the maternal health and weight gain are the first, antenatal steroids. So these are both perinatal, antenatal factors. Then best practices during the delivery time, asepsis and bundle care, postnatal weight gain. The breast milk is very critical. Oxygen management, lung therapy, anemia, judicious medications, especially antibiotics, and of course, if all this is not available, let's say the baby came from a bad center where things were not good, he was given heavy oxygen, nurses were not there, whatever. But a timely screening for ROP within 20 to 30 days of birth, we can still save these eyes. So I think as ophthalmologists, we should be aware of these factors. We should educate, have a dialogue, and keep on seeing that these factors are in order. Then our treatments are going to be very good. So coming to some of the questions about the risk factors, yes, the babies who are not treated well with all these factors, they will get more severe APROP. They will also get more severe a lower gestational age. So the younger the baby, the more chance they will get APROP, and the more chance that it will come much earlier. Although the earlier data, if you look at the cryROP study, they said that ROP will occur later in tiny babies. But then they put an asterisk there, and this is an American Academy guideline, that they don't have sufficient babies in that group. Now, of course, we have sufficient babies in that group, and we are seeing, and even there are a couple of editorials from the West that are we missing babies because we are seeing them late. So what is late? I think if you see stage 3+, it is late. We should have seen the baby when it was stage 2 without plus or with plus. That means, type 1 ROP, and we have treated it very early. Then they won't get traction and psychiatric changes and the macular scarring. So if we see APROP with new vessels already there, or vitreous hemorrhage or pre-retinal hemorrhage, so it is late. So that means we have to see within 15 days, 20 days. So we were seeing babies at 30 days, but then we were seeing APROP very severe fulminant at 20 days. So we shifted, we said we'll see within 15 to 20 days. So that is very important. Then if there is an avascular periphery in a full-term baby, it's very important to know how to differentiate FEVR retina from ROP retina. There's a whole talk on that, but briefly, an ROP retina always shows growth. It may show haywire growth, it may show normal growth, but the vessel will always attempt to reach the periphery. They will dichotomously branch, or even if they get a new vessel, they'll always be attempt to improve the vascularization. And mostly, if it has not been given anti-VEGF, it will get vascularized. Even in stage 4B, it will get vascularized. Whereas in FEVR, there's an arrest. The vessels will just be there. You keep on screening day after week, nothing is happening. They are just there. They are not growing forward. They may get into new vessels, they may get into traction, but everything is happening at the place where you found the vessels on your first visit. So this is very important to differentiate. Of course, there are other differentiating features, but this is an important differentiating feature. So same thing for Roper. So Roper is where you get FEVR-like disease, but the baby is preterm. So there's nothing stopping a preterm baby from getting FEVR if it has the genetic markers. So again, that will be one of the clues. And of course, they will have very severe fulminant disease. And even if you treat with laser, it will come back. After laser, usually disease doesn't come back unless you have given anti-VEGF. But here, even in spite of laser, it will start coming back. Also, this will happen in eyes which have persistent fetal vasculature. So this we have known. It has been published in one study. I wish we had collected the data and published, but we know this from our clinical thing that if there's a persistent fetal vasculature, that eye will get stage 5. Otherwise, I will remain in stage 4A. So if you are lasering somebody and there is a persistent fetal vasculature, think that this eye might go into surgery. And I think the perinatal systemic therapy I already said.
Thank you, ma'am, for covering all the questions and a wonderful presentation. I just wanted to, we have a minute and a half, so I just wanted to reiterate what Madam said about the Roper and FEVR. Of course, there's nothing preventing a preterm baby from getting FEVR. And she mentioned the fact that in FEVR, the blood vessels simply don't grow forward because mainly it is a defect in vasculogenesis. So it's an abnormal, the genes are going wrong where normal vasculogenesis is not taking place. As against ROP, where there are local factors, systemic factors, and therefore it's a defect in angiogenesis. But she mentioned something really important there, saying that if the baby was not given anti-VEGF. So what happens when we give, in case of ROP, when we give anti-VEGF, as Michael Tracy says, we are almost converting the phenotype into an FEVR. So in those babies, the rate of growth and the growth itself of these vessels after the injection, its recurrences and its management is different. And it may not mimic the normal ROP. And I'm sure Professor Dogra will cover that in his talk, but I just thought it was relevant to speak about that here. So I think we've kind of covered all of those questions. And she also mentioned in large for gestational age, what are the factors to look for? And I think that's really important, the diabetic mother, and so on. And if you see it in a full-term baby, then you just follow up, make sure that the avascularity goes away. Or very rarely, it might be Roper, and you might need to treat it.
So one of the immediate things you should do is dilate the parents' fundus. In 20% cases, you will find FEBR in the parents or siblings. That makes your work very easy and fast. And or the parents may tell that, I lost one eye or I was operated for retina. Then you know that, okay, this baby has FEBR gene.
Thank you, ma'am. So I have the pleasure of doing the next talk. So I've just actually added my questions in the first slide itself. So I'm moving on. I have no financial disclosures. So my questions are: which laser, how confident to make the laser, where to do the laser, and who will monitor? Is it a single session versus multiple sessions? Posterior to ridge, when and what are the indications? And laser after anti-VEGF. So it is still the gold standard. Anti-VEGF is coming up, but that's another talk. I just want to bring the, I have no financial disclosures here, but Tropac P Semi is back into the market. And for those who are interested, that's the phone number of the ophtho company, because the Oropen Plus was taken off the market. Which laser? Well, Dr. Dogra's group has shown many years ago that the green performs so much better than the diode. And I think, all of you who are doing adult retina as well, that laser can be used for your diabetic retinopathy patients as well. So the green laser is the way to go forward. Pre-treatment, Madam mentioned the anemia and the thrombocytopenia. Analgesia is something that's important. Almost all of us are trained to do treatment under topical anesthesia. So what we do use is, of course, topical anesthesia in the form of proparacaine, but we also use these sugar pellets. So sucrose was what was mentioned in literature, but 5 to 10% dextrose just does the trick. One important trick to make the baby comfortable, warm, prevent hypothermia, and you comfortable to prevent movement of the baby is the correct way of swaddling the baby. So always use linen, don't use synthetic cloth because it stretches and also the sweat absorption is not as good. Separate the two hands. If both the hands are in one fold, then the baby tends to be more feisty and moves off the folds. And of course, in our setting, we keep 1 foot out, and that is to plug the pulse oximeter. But the majority of their surface area is in the face, and you don't want to be exposing that. Also, the drops that you keep putting onto the cornea during the laser to keep it moist, a lot of it falls on the side and makes the cloth wet. And that itself can be a risk factor for hypothermia. So make sure that it is dabbed and this whole area remains dry. What is the correct position to place this baby to do the treatment? Well, any surface, as you can see, this is me trying to do it on the top of the RecCam shuttle. Of course, this is not always advised, but the correct position for your ergonomic best setting would be about a palm length below your umbilicus, and that's where the nose of the supine baby should lie. How many spots? Often we are asked, and I don't think you should be counting the number of spots as long as all the avascular retina is taken care of. A rough thumb rule would be about 2,500 spots or less for anything that's not APROP. We've gone up to 4,500, 5,000 spots and even more. But again, don't count. And as this montage shows you, you want to be about half a burn width or almost confluent. So when you're about half a burn width apart and you have this very smooth contoured laser posterior border, then they heal very well rather than having a very jagged edge of the way you would treat. And when this heals, it heals with a syncytial scar. So the scar doesn't have any gaps. All the avascular area is taken care of. As soon as you see tunica vasculosa lentis, it's not an indication for anti-VEGF, although that is one of the indications. If you just massage the eye as you go around trying to examine 360 degree, more often than not, it will dilate. And despite this angry looking TVL, you would be able to look through the pupil and actually complete the laser. Now, what happens in incubator-dependent babies, as Dr. Dogra's group has shown several years back again, that if you have a sloping wall, you can actually put your hands into it and treat this baby quite successfully. So again, this is a good caveat for your neonatologist. When you can treat a baby through the incubator wall, why can't you screen these babies? So don't wait for a baby to get healthy. It's the sickest babies who have the worst disease. So screen on time and tell this to your neonatologist friend. Now, chemosis, sometimes, especially babies with anasarca, low protein, they'll have chemosis even when your manipulation is very minimal. And this can sometimes preclude the view of the retina if it falls on the limbus and on the cornea. So you have to be just patient and move around this chemosis, as you can see in the picture, and then you'll be able to complete that. Almost always aim to complete the entire laser in one session. The exceptions are possibly in APROP. So when in APROP, when you're addressing the flat neovascularization, then you can either treat on the NVE, and I'll show you that in a picture shortly, or treat up till the NVE, wait for the NVE to retract, and then go ahead and laser on the ischemic retracted edge about a week or 10 days later. So if you can see this, these are the laser marks that are about a week old, and this boat-shaped NVE has now moved posteriorly towards the macula, exposing this ischemic area where the NVE was sitting. So if you go back and laser on the NVE now and that ischemic retina, then you get the best outcome. You will get no lingering ischemia, and you won't have any fibrosis as well. My next few slides are all going to be cases. I'm going to move them fast. My preference for even a zone 1 ROP, if the fovea is vascularized, and we do here a lot of angiogram on the REDCam 3, is still laser. Of course, this was way back, this about many years ago. Sometimes these cases do much better with anti-VEGF, and I have an example of that as well. So when the pupil is small and the media is a little hazy, one good idea is to go around the posterior border like this. So when you're doing this, you have in effect massaged the baby's the globe, and the pupil dilates as I showed you. The next thing to do is to mark out the ora serrata with a few spots. We do this routinely when we get our fellows to do the laser, but you can do it yourself. Even with a lot of experience, what happens is after some time, the ora serrata becomes obscured, and sometimes you don't want to be over-treating into the pars region. So marking out your anterior most border is a good idea, and then all you need to do is go around 360 degrees and complete it. When you complete it, look back at what you've done and decide, okay, can I go more posterior or can I wait another day, another week? Because many times you don't need to go more posterior and invade the macula. You must be very aggressive nasally, superior and inferiorly, but temporarily you can get away. And I'll show you one more example. So, and then fill in a few days later, a few weeks later sometimes, just with a little, and then they do extremely well. If you have a smooth laser scar like this, they do very well, not just in structural outcome, but also in the amount of myopia. We have now a single-digit percentage of myopia after laser, after we followed this technique. In this rather mid-dilated pupil and a hazy media and the AC looking shallow, you can still complete a laser. And in this one, we did not prefer anti-VEGF because of the already early traction, and we were scared of the crunch. So what we did was, we did the laser thoroughly. You can see that this crescentic area is left behind quite purposefully in the temporal side, but everywhere else, it's a thorough laser. That's important here, that you don't leave out anything in all other quadrants. A week later, you can see that the plus is melted away, and you can only see a bit of the ischemic retina in the temporal and the upper temporal region, and then you can complete that. Now, it looks so angry just after that second laser, but they do so well. And this is another 10 days later when they heal very well, and then there's no recurrence after that. A third case, now in this case, you can see that it is really thinned out obliterated vessels, and these are the cases that probably do much better with anti-VEGF. And also you can see here that the ischemia is in the posterior pole. So in this case, we gave anti-VEGF, and one of the questions I was asked is that when would you do a laser after an anti-VEGF? And this is a very difficult question to answer in one word, but here's the collective experience of a lot of people. So after this baby was given an injection, I'm just following up this baby, and you can look on the top left, that's the timeline. 3 days later, we've repeated the angio, not necessary, but this was many years ago, and we were trying to look at the natural history. A week later, the plus comes down, the blood vessels are growing. 2 weeks later, I'm just going to fast forward a bit now to show you 2 months later, there's a lot of avascularity still. 10 months later, what looks like maybe a nicely vascularized retina, when you do the angio, you see that they still have leaking buds. So this is really the question. Till when would you wait for these, for the vessels to reach the ora serrata? When would you intervene? Would you, of course, if there's a recurrence, then you would intervene much earlier. But if it's just growing naturally, is there a weight cutoff? Is there your comfort zone saying that more than 5 kilos, I'm not comfortable doing under topical anesthesia? What is it? So I think that's a question that we'll be answering in the panel. But here we, in our center, we use the angiogram to actually delineate where we need to laser up till, especially in these much larger, more difficult to treat babies, and then they do well. Okay, so this is an example. I'm going to move directly to the point that I want to show, where here in this case, a large amount of the temporal retina is spared, where aggressive treatment is done elsewhere. Just to show you that not all babies, you need to come back and fill that temporal area. This eye, for example, all we did was stop here, and week and months later, it had never required any more treatment in that temporal area, and it grew very well. So it's about customization and also the systemic risk factors of these babies and how well it's controlled after laser. But here's an example of a lot of sparing that you can do in the temporal retina, giving a much better refractive outcome as they grow older. Here's a case which had a congenital scar in the macula, which was given anti-VEGF elsewhere. The child was many months after treatment, and when we do the angio, you can see that almost a third of zone 2 anterior onward has the avascular retina. Now, these are the horrendous cases that we all see, the so-called zone half or the posterior zone 1, and here, hemorrhage, disc hemorrhage. These are clearly the cases, indications where you would like to start off with an anti-VEGF and just hope that that is enough. You can see that the hemorrhage does well, the plus comes down, all that ischemia is coming down, but then there's a recurrence. Fortunately, many weeks later, and the recurrence is now in zone 2, and you can take care of that with laser. Posterior laser, these are actually two halves of cropped images, just to show you that if you're faced with a situation where somebody's treated this baby and sends it to you and the ridge is still persisting, what do you do? Well, before running into wanting to do surgery, you can actually salvage many of these eyes with posterior laser. And this is called secondary posterior laser when you do it after somebody has already done a primary laser. And you'll see that many times, if not most, you will be able to take care of that traction. Of course, another sitting of laser in between that traction may be required after a few more weeks, and then it completely flattens out in many cases. Another example of laser is buying time or indeed avoiding surgery in stage 4A. Here's a ridge that could have been easily taken care of with laser in the right eye, but I want to draw your attention to the left, where this exudation and almost 4A-like picture is going on, and then you do the posterior laser, and then it really comes down, and sometimes that's the only outcome you need after surgery, and you're getting that just after laser. This is a laser that you've done, and this is quite the example of the other case number 3, where you have to go back and do this supplement laser temporally. But as you can see from this day to about 2 weeks later, the amount of laser that you need to put temporarily has come down. So sometimes patiently waiting for this ridge to develop after your first laser will save a lot of extra treatment. So in summary, cover all the avascular regions, plan AP-ROP if you want in stages. And I just want to show you the Iroc guidelines. We are still in kind of the pandemic area, and this is available on our website. So you can treat a little earlier than type 1 category, because many times our patients are not able to come back for follow-up in time. And that's what we've put up on the website, and I'm not going to go into the detail. I want to just thank all our contributors, Dr. Subhadra Jalali's team, Dr. Ajay Kapoor, who've been treating through this pandemic and making sure that babies' vision is not lost in this amenably treatable condition. Thank you so much. So I actually covered my question and answer.
Anand, I just wanted to add one thing,
Yes.
if I may.
Sure, please.
See, the thing is that you mentioned about those drops trickling at the side, and that is another risk factor, for the child. So what I generally do is that a whole wad of tissue papers, I put it here under the cloth, so that if there is any kind of fluid which is going because of the drops, it gets soaked in that. So that's a very easy way of overcoming this problem.
In fact, you have wonderful videos also on showing the sugar pellets, which we all
Yes.
love to see. And so it calms the baby down. It certainly calms us down. It takes care of hypoglycemia. And there have been studies that have compared sugar with breast milk and placebo. And breast milk works just as well, but it's the viscosity being a little lesser. One has to keep, using it,
Dipping it.
wetting the wick of the pellet,
Exactly.
but that also works.
No, I mean, to test this out, I had done this as a comparative thing where I'd put dextrose, dipped and vis-a-vis a sugar pellet. And the dextrose, they keep crying in between. Whereas the sugar pellet, they keep sucking on it and they're quite comfortable.
Yeah, Anand, I just wanted to add a couple of things. One is this I have been telling before also, that whenever you are getting good burns, keep on reducing your power so that you get no burn, and then you go back to little hair burn. So do it as a stepwise thing, because especially new fellows and others also, they are so excited to do the laser that the burn is not coming, so they keep on increasing the power, and then the burn comes, and then when they go to the anterior retina, they actually create holes, or they create anterior segment ischemia. I have seen so many patients anterior segment ischemia by somebody. I had one case, but thankfully that was the only one. So the energy is very important, especially when you are giving burns to an eye which has had an anti-VEGF. Again, there it seems that the retina is thinner. I don't have OCT of the peripheral retina, but clinically it seems that retina is thinner, because we know that retina is very edematous when there is very fulminant ROP. So you may require more energy, but in these thin retina, especially peripherally, temporally, please keep on reducing the power. Whenever you get good burns, reduce the power, because you cannot judge what is more white than white. And second thing is, although we are saying confluent burns, that doesn't mean that you have to put burns on top of each other and really make it like a big white snowfield type thing, because the burns also enlarge. So we don't do one burn width apart like in PRP in diabetic, but you just do burns which are just very close to each other, but they don't have to overlap, because they will grow, they spread. So, so these are two things which are very important for you to not get side effects of laser, which includes anti-segment ischemia, which includes exudative detachment, which includes breaks in the retina. And we are seeing these more and more.
So two things. Thank you, ma'am. Thank you. Those are very practical points. I
Another
would
thing
like
which
to
I
add
wanted to
that,
highlight, you very properly said that not all patients need surgery for, especially when if they're in stage 4A, you have these cases where you get a little traction on the nasal side, especially if they have been referred, irregularly treated. And many a times when they come as referrals, you see that these children have not been lasered adequately. The periphery, absolute periphery, has not been covered. So, first examine that area, fill up that area, and if you feel there is a nasal traction which is ensuing, it is better to give a little wide arm and do a laser treatment and see, because I have got a few children who are big now who are still holding on with that kind of laser treatment and nothing. And vis-a-vis, I've seen patients who have gone in for surgery and the outcome has not been good.
thank you, Dr. Karoli. I think we've kind of come up to the end. If there's time, I wanted to add something about topical steroids after laser, but we'll do that in the panel. Let's move on to the next talk. In the meanwhile, Professor Dogra, my teacher, and all that I've learned from him. So, sir, over to you. And sir's going to talk about anti-VEGF in ROP.
Thank you, Anand, and all of you here. I think I'm just going to talk a few things about it. Why basically, I think when we published in 2009 in Retina, we saw that the unfavorable outcome was almost close to 30%. And we also looked at other study of zone 1. Those days, you can see here from Chile and from US and other countries, the percentage was quite high. So, and here, of course, this is a recent study where we only did laser. 79% of the eyes had an unfavorable outcome if it was a posterior zone 1 or a zone half ROP. I think, these were some of the things. I think this is the zone, what they call as posterior zone 1 or zone half. You can see it, they are not reaching even the fovea, and it is just by the side of the disc here. And in this, the laser was done, even the stretch breaks occurred. And so that is what is the problem. And we may have a situation like this sometimes, although Anand did mention that it can dilate and stretch like it happened in this case also, but sometimes it is so hazy, you can't do much of treatment, incomplete treatment, or sometimes even you may feel that this is the eye, when it is manipulated more, they start even a little bit bleeding or oozing. So, or eye like this, those who need like perhaps something else to be done along with laser. So basically, I think at this time, zone 1 and APROP are less responsive when need laser. Difficult situation I have shown. And sometimes the disease may progress despite your good near confluent laser, which nicely mentioned by Dr. Subhadra. And anti-VEGF may be followed by less extensive laser. That is what is a big advantage, I think. We are not killing the whole retina. Of course, we all know that it started all with this BEAT-ROP study, which had given us that zone 1 stage 3 is the preferred modality for this. And now, of course, with the Rainbow trial, and also I think if you go to Cochrane review, I think we have a here from RP Center itself, Parijat Chandra is also part of this Cochrane database review, and that anti-VEGFs are slowly becoming more acceptable all over the world. Most would use in APROP and zone 1, I already said, and recent trial has advocated ranibizumab for type 1 ROP, because this has been approved. That's how many people now feel more confident. After anti-VEGF, additional laser may be required for reactivation or persistence of disease. And the late recurrences and systemic advance are a concern, but I think as we are following them longer, our concerns are sort of going down on that. Of course, injection is simple, easy, and does not require special expertise, possible under topical anesthesia, and we get a rapid response. That is what is very important. I find that laser takes time, and here you would have a very rapid response. You may preserve more visual field, less myopia. Well, that is still sort of there, debatable, but definitely these cases, since we destroyed less retina, I think that is what basically our aim is. What are the problems? Even the questions which are were put to me, some of them would be answered right here. We don't know whether we should do purely a monotherapy or a combination therapy. I think we need both. Sometimes it is monotherapy may be good, but combination may be required in many. Which anti-VEGF and dose? Big debatable question. Still many people feel Avastin is more effective, more this thing, but then there are other issues with Avastin. Even the systemic absorption is more, which has been shown. And dosage still about even all anti-VEGF. We are not sure. Most of us still use half dose because that is what Rainbow trial used. Eyes treated with anti-VEGF should have a long-term follow-up. That is very important. We don't know the duration. Again, somebody is going to ask, what is the duration of follow-up? We don't know how long we have to follow them. And the late recurrences are possible. I'll show you example. And systemic adverse events still, I think this is a concern. I think I'm just showing you one baby here. I think this is way back in 2016. And you can see this is status post Eylea. Half a dose has been given, and you can see how well it comes down very fast. And then you could laser and get a very good outcome. And laser is perhaps not required. This is also a question posed to me. If the vessels have reached zone 3 or has already gone to Serrata, of course, then and there's no reactivation. In fact, Dr. Swadra would remember there was a great lecture by Susanna about FA in such cases, and she had shown certain features that if you see these features, of course, we can't do in every case. Then perhaps we can watch. So that is also very important, which cases we can watch and which are the cases we have to laser. I think that is where we have to work also. And that is where I would request Anand, since he's working on that, he should work on in that area. And of course, ideal at this time is a deferred laser. So wait till the time the vessels are growing, the disease is not coming back. It is not really, although we don't know what would be the exact point at which we will laser. But deferred laser definitely will save more retina. And anti-VEGF injection will be followed by, and I already said that, less laser. And of course, combination is still required for AP, ROP, and zone 1 ROP, but more so always in posterior zone 1 ROP. Maybe here the surgery would also be required in many cases. So all three may be required. And you're going to ask me which combination should be done first. If you have more traction, you have something like a blister like ROP, or you have already raised, then first do the laser and then anti-VEGF. In case you don't have proliferation, it is like a typical AP ROP, zone 1 ROP, then you can first give a, anti-VEGF and subsequently may do laser if it is required. And inadequate laser treatment due to hazy media, I already mentioned about that. I've shown you some of the examples, and these cases definitely they get benefit. I have shown one case here. You can see there was a vitreous hemorrhage, and in this case, we could have a successful outcome. Even Zhao has published such cases recently. And combination of laser and anti-VEGF, I think I have already mentioned this. I'm not going to repeat this again. And this is something which, and I just wanted to show you, I think typically we were doing this. We were going all the way here. And then somehow we started sparing zone 1. I think that is what. But at this time, after anti-VEGF, if we let these vessels grow into zone 2, and if that stage we need, I think we are saving a lot of retina. I think that is what, in fact, our this thing should be. But I don't know still, I keep showing this many a time. Some of you have seen this. Despite anti-VEGF and good laser, there was a problem here. We didn't follow for some time, and we got this kind. I thought if we had seen like this, I must say, it is a proper laser, good laser which works, not the inadequate laser, which happened with many people. That's how it does. It fails. If you have done a good laser, it will be definitive. Also, the laser has another advantage, which I keep telling also. If you have lasered the retina all the way, I think that late retinal detachment or the late problems are never going to happen, because they will all happen in anti-VEGF eyes, because we'll have a lot of changes happening in the periphery. So that's why long-term and follow. So in conclusion, I would say most use deferred laser after initial anti-VEGF at this time for AP ROP and zone 1 ROP. And obviously they use before anti-VEGF because of rapid response. And indication for laser in ROP are decreasing and changing. I think soon we'll not have now ETROP guidelines for laser. We'll have a different guideline. These are also going to come soon. That is what would happen. And anti-VEGF injection is mostly followed by less laser. This I have emphasized. And we need a deferred laser. It helps to preserve more healthy retina. Maybe the visual status itself may be better. I think that's what we need to preserve and do. Thank you very much. I think I'll be open to all the questions or whatever would be.
Thank you so much, sir. I think in my excitement, I forgot to list out the questions. However, you answered all of them, but I just want to reiterate, and there's probably one left. I want to reiterate what the questions were. Drug of choice, you said ranibizumab, mainly because it's been approved. Half dose or lower, yes, we are now giving about half or 1/3. We like to believe 2 units is about 1/3. We want to give lesser than that, but it's difficult because, you know, unless you use the David Wallace techniques, getting a further dilution and putting it into the eye is difficult. Then you spoke about recurrences and how do you manage it. And I think you said that you will not manage it giving the second injection. You would give laser, and your idea would be to wait for the vascularization to go into at least zone 2, if not further. One question, sir, which remains is that your ideal location to give this injection, would it be the operating room in the eye hospital, or is it still okay to give it in the NICU? And what extra precautions would you take?
I think the most important, if we can, ideally, we should give in operating room, because we are more comfortable there, as well as all other things are taken care of. And because we are also giving in both eyes at the same time. You see, so we have to take all the precautions, which we can take very well if we are in the OR setting. But then we have to give sometimes in the neonatal intensive care unit area. I think there we have to be very careful in a way. I think we must take all the due precautions, whatever is required. as far as it should not be taken just like that, that you just put a retractor and just put a drop and give injection. I think take all precaution what we do in theater there also. And although we have to do sometimes right inside the incubator itself, or maybe just outside that, because these are the sick baby, that's why we are doing it there. But with all precautions which we take in the theater, that is the way I would go. And also talk to your neonatologist or a pediatrician. They would be extra things telling you about there, which is the best place, or they can help you where they do their own procedures. Sometimes they do some procedures which are also quite invasive. So I think that is the way we should go.
And you brought out the next question, sir. Bilaterality. What is your thought on giving both injections on the same day, vis-a-vis giving one today and one tomorrow? Logistics apart, what do you think is the right thing to do legally and clinically?
I think absolutely, I agree with you, Anand. It is a lot of stress for us, especially in our country. But the problem is, since the disease is aggressive, we are giving for aggressive disease, we tend to give the same day. That is why. And we also feel at times, yes.
Any special time do you require for giving injections on the both day, on the same day?
Yes, mostly, yes. That is what we are also doing. In fact, not only that, now Parijat is here. Diksha has also started doing bilateral sequential surgeries. She does all ROP, and Subhadra is here. Because I think if we take both eyes as separate, that is what is very important. That is what I would tell all the time. Even for injection, take all things as if you are doing two different patients. That is the way one has to go. If we go that way, I think we will not land up. And we have not really, by touch wood, I would say here, we have not seen anybody reporting problems of a bilateral endophthalmitis till now, because a lot of injections are being given. I think that is what is important, and both Subhadra, Parijat are here, and as I told you already, Diksha is doing that. They do bilateral sequential surgeries these days for all cases most of the time. And I think it is only because of this reason that you take all precautions. You go as two totally independent sort of surgeries. I think it can be done, and I think it will be possible. Yes.
Thank you, sir. We've come to the end of the time for this discussion, but we'll have a little time after Parijat's address. Dr. Parijat Chandra, over to you. He's going to talk to us about ROP surgery, when and how.
So thank you so much, Dr. Anand. And it's my privilege that I get to speak alongside many of my teachers from whom I have learned everything. And many of them are here in this session, and I'm very grateful to them for all I know today. So I'll be talking to you about surgery in stage 4 and 5 ROP. So we are aware that a lot of challenges are there, a lot of preoperative challenges. You need a strong anesthetic team. You need a good NICU backup. And obviously, there's a lot of risk of complications when you're dealing with small eyes. So I'd like to show this because this case came to us. He was a case of stage 4A developing both the eyes. He had already undergone laser in both the eyes. Unfortunately, the child could not be cleared for surgery. So this is how he came to us at 2 weeks when he was fit for surgery. So you see, a lot of things have changed. The message which I want to give in this case of stage 4 is that you see the ridge is now much worse than what it was. It's bleeding more. The maculas got involved. The height is more. So we need to understand that as the case gets delayed, more height happens, more peripheral, becomes more vascular. The instrument access becomes difficult, as well as the outcomes become poor. If the lens gets involved, there's a high chance you might not be able to save the lens. If the macula gets involved, even after best of surgery, the macula might pucker and the visual outcomes might not be good. So how are the outcomes in stage 4? So you see the case on the left, it has a very high TRD developing here. And if you see on the right, after surgery, it's just gone away in 4 weeks, as good as new. So the outcomes after stage 4A surgery are very good. Same case I showed you earlier, this case was operated, but although it appears that the ridge and everything disappeared, but see the macula is puckered, dragged. So the outcomes are really not good. So we need to operate early, and we should not delay in referral. Just to show you a case of a 25G vitrectomy, which is being done, lens sparing. So you see now the band here is being relieved, which is pulling from the disc to the temporal TRD. Now the vertical traction is being relieved over the ridge. You can see the laser marks are already there. These have been given fresh just before surgery. under GA. So you can see the ridge is bleeding right now. So you can just go ahead and diathermize all these bleeding points. The idea is to relieve the entire traction vertically so that the pull stops. You can see the central circumferential traction across the ridge is also been cut and it's no longer there. So the idea here is this is what it looked like. And this was the vertical traction which was there, which we need to relieve. We also need to relieve this tangential or radial traction, which is pulling it, as well as the circumferential traction. So unless you relieve all these three types of traction, something or the other is going to keep on pulling and it will not be a good outcome. There's another case which has a little more of posterior TRD. It's a case of zone 1 here, as you can see. Again, fresh laser marks you see have been given prior to surgery. You can see how yellow the vitreous is right now. And once you do the vitrectomy here, relieve all the traction, then you see right now that all the yellow vitreous is now gone. You can see even the macula is not vascularized here. And we're trying to do some PVD here. And so this is how it looks like at 4 weeks. And as you can see that a lot of this traction has gone away. So this is not to say that, the outcomes of these cases can be universally good. This particular case, if you see, it could have a very bad outcome as well. So we were lucky we got away with this, but this is a late stage to refer a case of ROP. We need to get these cases a little early. Okay, so let's see this another scenario. This case came to us. This is what it looked like. We continued to follow up this case. He was being regularly referred by a private practitioner. And, one day, even after best of laser and laser augmentation, as you see here, this started to lift in one particular area. So after 4 weeks, this thing happened and we advised surgery in this case. However, the parents were not willing for surgery. So unfortunately, this is what it came at the end of the next 2 weeks. So you can appreciate that it progresses very fast and an outcome which could have been better in the middle photo is now much poorer in the right photo. So we need to go in whenever a patch is lifting up despite surgery. And obviously Anand has given very good insights into a good laser. And again, this article about technical aspects by Dr. Jalali and some of the teachers here is very good if you need to start getting practical tips on laser treatment. So we should not be waiting for the ridge to become like this and keep on praying that the ridge will somehow go away. So if it come like this, then it becomes very difficult to treat this kind of cases with the lens sparing vitrectomy. So this is just to put in a word for all nasal approach, which Professor Dogra likes to talk about. And this is a screenshot from his paper. And this is basically a very good approach if you've got a temporal 4B and you can go through the nasal approach as you see here he's going. And then you can relieve the traction from one side and it works very well. So there's some of the cases which we get where you have zone 1 stage 4 and is developing. But here what you see is that the neovascularization is very severe. So in these cases, even despite laser, if you see it's picking up, if you do surgery, there's a high chance you'll have intraoperative bleeds, post-operative bleeds, and then it might just pucker up and close. So we do like to combine injection anti-VEGF with these drugs intraoperatively. And then, this kind of outcome can be obtained. So we find that anti-VEGF combining selected cases only, where there's extensive neovascularization and you can get in early, it works very well to help in these cases. And obviously, as Sir said, that in bilateral progressive cases, we do like to go in a single sitting. And we again learned it from many of our teachers, how this is to be done. And so it works very well. We don't waste time to let the better eye progress to become worse if we do it one after the other. Obviously, you have to treat it like two separate eyes. And if you do it that way, then, you can have a good asepsis and it can work very well. Obviously, parent counseling is very important in these cases. Complications are a big problem of this story, especially for newcomers who start because they have to, and especially if you're coming from an adult eye, then you need to be aware that there can be complications because they're smaller eyes. Instruments are not meant for very small eyes. So in this case, you see the instrument went in, caused a break. So you just need to go ahead and, laser that area and there's no problem which happens after that. Don't do a PVD. Don't try to, mess too much with that area. Again, this is a common problem because the eyes are very small, the cannula can bend and can cause lens touch. So again, if the capsule is intact and just a pressure touch there, then, you can get away with it. Sometimes the cannula does misdirect and lead to suprachoroidal misdirection of fluid. Again, you can let the fluid come out and then, you can again, the outcomes can be good in these cases. And obviously, post-op hemorrhage is a big problem. So don't leave bleeders on table, and this can again be helpful in those cases. So stage 5 ROP is again a big problem. Many of us deal with these situations, and right now we get around 5 to 7 babies of stage 5 ROP coming to RP center. It's a very sad situation that so many babies are going blind. And we all started learning from Dr. Gopal, his earlier paper, which came out, which shows the learning curve. So we got inspired by it. Many of us started operating from tips and tricks from that. And again, this is an idea of how the thing lifts up. So what this article by Dr. Sen is trying to show here is how this traction tends to lift up, how you have ridge to ora traction, how you have ridge to ridge traction. Again, this is useful for people who operate stage 5 ROP to understand the pathoanatomy with which you're getting into, so that you know how you have to relieve the traction in these cases, which is a little different from the stage 4 ROP cases, which you deal with. And obviously, ultrasound is useful, but again, it's of limited use. If you go in and you can able to separate the retina, some possible useful things. So just to show you the technique, this is how I like to do it. So here you can see 23G MVR is going in. So through these 23G instruments, through the 23G MVR, we put in 25G instruments, and it allows for good sutureless closure later, and allows easy access to the instrument. So you see lensectomy is being done here. All the posterior synechiae, etc., is being relieved. This is the retrolental membrane. So an opening is being made in the retrolental membrane using the MVR. So you have to be careful here. Don't go ahead and cause a break in the retina, which is just stuck behind this. So once you continue to open the retina and you continue to dissect it, the retina does tend to fall back. So this is a case of open funnel configuration. So this is one of the better funnel configurations. Many of them are closed and things like that, and then they would not open so well as this can. This is to show you how these retinas can open up and why surgery should be tried in these cases, because there is hope. So you can see now all the traction is being relieved, and once you keep on dissecting this, you can see the disc is there, you can see the posterior pole is there. And obviously this 360 traction you can't relieve because it's all very dense and tight. And here you can see the hydration of the wounds can be done, and then it becomes sutureless, night clean closure can be done. There's another case of stage 5 ROP. Again, you see the same approach. 23G instruments are going in, and through the 23G MVR, 25G instruments go in. Again, lensectomy is being done, the posterior synechiae are relieved. So it's again a case of open funnel configuration. And you see there's just fibrous tissue in between. The retina is 360-degree dashed, but the central funnel has just fibrous tissue. Not much dissection is needed here, as you can see.
Recording in progress.
I'm just removing the central tissue, and there you can see the disc is there, and this last bit of tissue is going away. And as you can see, there is the disc, there is the macula. Although the macula is not so healthy. So to say that surgery should be tried in these cases, I'm not trying to say that the outcomes will be good in most of them. The outcomes will typically be very poor in most of them. But if you try surgery, there's a chance the child might get navigable vision. And even if he gets shadows, if he's able to move from one room to the other without banging into the door or the chair, then you know his life changes. He's able to recognize shadows. He's able to recognize his parents are standing there. So his life changes. And you really don't know which case might actually open up very well at the end of surgery. But typically, we should be avoiding stage 5 ROP because if you can laser early, do anti-VEGF early, and these babies don't reach stage 5 ROP, then you know it would be much better. So thank you so much for this opportunity.
Thank you, Dr. Parijat. And I think the best person now to call for the panel is Dr. Lingam Gopal, sir. Sir, I can see that you are logged in, and this used to be your instruction course that we've been doing for so many years. We really miss you today. So could you please come and, this is the best time for you to come in and actually talk about the course and, of course, the whole surgical aspect, which you pioneered so much in this country.
Right. Thank you, Anand. I'm sorry that I'm not going to put the video on because I'm not really interested to kill. So I'll probably just have the audio on. I really enjoyed all the presentations. They were very lucid and very concise and beautifully done. I thought just one question I had for Dr. Dogra. That is for anti-VEGF. I thought there's one other indication would be a lasered eye, which is not responding well, could sometimes respond beautifully with just one small jab of anti-VEGF. You've already done a very good job of laser. Of course, sometimes we do a little posterior to the ridge laser, but some cases don't respond, occasional cases, but they do beautifully well with just one jab of anti-VEGF. Do you have any experience with that?
You're muted, Dr. Dogra, you're muted. You're muted, Dr. Dogra.
Yes, yes, yes.
Ah.
Absolutely, Dr. Gopal. I think what you said is very important, and that also brings the case, perhaps what Parijat had shown. You see, what I have observed, and I didn't point out that there are some cases where you still have dilated vessels. After your good laser, you've done everything. If you have dilated vessel, that is definitely going to progress, whatever it may be. If your vessels have come down, it will stay there. Many a time we do, I mean, Anand also shares sometimes these kind of cases with me after laser and all that. I know it that which case would progress because it is dilated still. It's a eye which will create a problem. So you are absolutely right. And I think if we can give their injection, we'll be much better off. And as well as we'll not have an unfavorable outcome. Absolutely, I agree. And that's a great point you brought out.
The second point that I would like to make is it that we need to change our mindset in terms of laser versus anti-VEGF, because we are all born with the laser and we violently talk in defense of lasers. But perhaps the need for us to change our mindset and thinking, because why I'm saying this is that we were dealing at one stage, and I hope we are going to come out of that stage, of neonates who were actually badly treated with oxygen. And hence we are not dealing with actually an ROP as a natural outcome of an eye which didn't get vascularized properly, but it was an outcome of an eye where even formed vessels have been damaged by oxygen. So suppose we have a situation where we know the neonatal care was good, and despite that they developed ROP. I think those cases as a primary treatment, slowly we can think of switching towards anti-VEGF, because there's enough and more data across the world indicating its safety. I don't think we need to question that now and expect thinking that the neurological development deficit, etc., could be an important reason why you should not use it. I think there is a lot of safety data now. So if we accept that anti-VEGF could be at least on par with laser in terms of safety, then I think these are eyes where I would first give anti-VEGF, even if it is mid-zone 2. I'm not talking about posterior zone 2 or a zone 1 disease, where even for posterior zone 2, these days I would do anti-VEGF first rather than laser, and then follow up with laser as and when required. But I'm talking about even mid-zone 2, where probably currently we still do laser. Maybe there's a need for us to change our mindset and give injection, and then of course follow up with laser if required, and provided we know the neonatal care was good. I'm not talking about those eyes where you got hardly any vessels seen in the fundus, and then you definitely end up with some problem or other. What is your viewpoint of this panel?
Absolutely. I must say that is what is happening. We have already changed our mindset. And there's another thing which is going to happen, I'm telling you, which is not going to be good. Now our younger generation is not going to learn lasers. So that is going to be a bigger problem. They will not be even able to laser what would be required, small laser to be done in the periphery. That is what is a problem. But that is beside the point. But what you made a very important point. We will be changing. I did talk about that. The guidelines for the laser would be changing. They'll be coming out soon. I think we'll have mostly now guidelines coming for anti-VEGF as the more and more studies are being done and more people around the world, they are comfortable. And despite being now laser being anti-VEGF being used for more than 10 years now, at least, no major problems have been reported as far as the side effects are concerned.
So Dr. Gopal, if I can just add that, I think every ROP surgeon who's going to treat should become fully well versed with lasers, with anti-VEGFs. And so you have both these things in your hands and you're very well versed with it. And you don't need to be dogmatic that I will use only this, only that. Once you master both the things, you can make a choice and you can discuss with the parents, and you can also understand what will be good for one may not be good for the other, because there are so many factors which influence what you use. But I think what you're saying is correct. We are using more and more anti-VEGF. Initial skepticism was there, and that is correct. Whenever something new happens, we have to be skeptical. We have to get the data. We have to see what are the side effects, how it works, how it doesn't work. And our clinical judgment can never be overruled. But the important thing is that we should be willing to learn. that I did something, the patient didn't do well, what went wrong, go back to the photos, understand what happened for any of the treatments, especially new treatments. And as we learn how the retina will behave, how the baby will behave, how the parents will take it, what the media is saying, everything we take into account, and then we make the decisions. And I think that is the best way a doctor can, manage their patients. So you're right. I mean, they are at equal par. I have no concerns about the safety part now. If my child has, I'm happy to give Avastin. I have given to my family also for, BRBO. So there's no issues. But I think what is not correct is to, give jabs without knowing why you're giving, without knowing how to follow, without knowing what to do, or just doing some partial laser, homeopathic laser, not knowing what to do, not knowing how to follow. So that is not correct.
Yes,
So I believe we've completed our very interesting instruction course. Thank you, Dr. LG sir, for making it. And let's hope that next year we all meet in a physical conference. And thank you so much for all the speakers having contributed. And until we meet again.
Thank you.
Dr. Dogra,
Thank you,
good morning,
Gopal.
Dr. Gopal. Sir, I still would make a request that you please come on for a second before we all disperse.
Sir, एक झलक तो दिखला दो. आनंद एक फोटो खींच लो.
झलक दिखला जा.
Anand, please take a picture.
Who says
Anand,
you're not
please
dressed
take
to
a
kill,
picture.
sir?
Anand,
Very
can you
nice
take a
to see you.
picture? Yeah, Dr. Dogra, एक picture ले लो. Rohit, somebody take a picture. I'm not good at taking pictures.
I'm going to just, yes.
Thank you, sir.
Okay.
Sir, you come to the center.
Thank you. Lovely to see you, sir. आपको देख के तो हमारा दिन बन जाता है.
Baag ho gaya. Thanks.
Thank you so much.
Bye, everybody. Thank you.
Thank you.